Hi class, welcome to this video lecture on chapter 12, Cost, Access, and Quality. So let's quickly just go over the learning objectives. The learning objectives for this week or for this chapter are that you'll be able to identify healthcare costs, their trends and underlying factors, discuss some regulatory cost containment approaches that were unsuccessful, describe nature, scope, and dimensions of quality, identify the difference between quality assurance and assessment, describe regulatory and market-oriented ways to contain costs, examine the framework and dimensions of access to care, and last is to be able to discuss the implications of the Affordable Care Act on cost, access, and quality. So I'm going to jump to slide 8 and talk a little about the term cost. So the term cost can carry different meanings in the delivery of healthcare. It really depends on the perspective one takes. So there can be 3 different meanings. We have a national perspective, which is that healthcare costs refer to national health expenditures. And in this context, healthcare costs are the portion of the nation's gross domestic product consumed by the delivery of healthcare services. As such, healthcare costs measure the economic resources a country employs for healthcare delivery. Now, from the perspective of consumers and financiers, healthcare costs refer to the prices charged by providers for the delivery of healthcare services and the prices of health insurance premiums charged by insurance companies. And the third kind of perspective when it comes to cost is from the provider's perspective, which are the healthcare costs refer to the cost of producing the healthcare services. And one thing we're all aware of is here in the US, we have rising costs in the area of healthcare. And I wanted to address why should the US control these rising costs. So I wanted to jump to slide 16 and just talk a little about that. Now, on slide 15, there is a link to a video. It's a documentary titled, "Why Does the US Healthcare System Cost So Much?" And then slide 16, here we are why should the US control the rising costs of healthcare? So the rising healthcare costs consume greater portions of the total economic output because economic resources are limited. Rising healthcare costs mean that Americans have to forego other goods and services. Now, there's also the issue of insurance coverage, which insulates consumers from the cost of healthcare. So there's this tendency to spend far in excess of what the expenditures would be under the free market conditions. And we also have rising healthcare costs that can erode the competitive position of American businesses in international markets. And there's also that Medicare and Medicaid are headed for bankruptcy unless rising healthcare costs can be contained. And last, rising healthcare costs minimize the ability of employers to offer health insurance as a fringe benefit. So unless costs are controlled, there's likely to be a greater number of uninsured Americans. Now, next, I want to briefly discuss how both prices and quantity of healthcare are higher here in the US than they would be in a highly competitive market. So I want us to jump to slide 21. And I just briefly want to talk about this a little bit. So in an imperfect market, utilization of healthcare is driven by need rather than demand. Utilization is increased when patients are insulated from having to bear the cost of healthcare. Providers are able to induce demand to increase their own incomes. Higher utilization means higher quantities of healthcare services are consumed. So in a highly competitive market, prices charged by providers for healthcare services are likely to be much closer to the cost of producing services. So this is because higher prices would lower demand for their services. So under imperfect market conditions, the prices charged for healthcare services will be permanently higher than the true economic costs of production. Providers are insulated from the economic impact of lower demand when prices are artificially set at a higher level than competition would allow. So health insurance also insulates patients from higher prices. Now, some of the reasons for increased healthcare costs are attributed to the providers of medical care. So to cover this topic, I'm going to jump to slide 27. And here we are looking at reasons for cost escalation, but specifically in the area of defensive medicine. So providers in many instances set their own charges, which are higher than what the same charges would be under free market conditions. Providers are in a position to induce demand for services, leading to higher utilization than what is necessary. And many of the procedures performed are medically unnecessary. Providers have done little to promote healthy lifestyles and the prevention of disease because they have mainly focused on the medical model for healthcare delivery, which focuses on treatment. But we are going through a shift where the focus is slowly going towards preventative care, or more emphasis is on preventative care. Now, because of the legal risks, providers have engaged in the practice, again, of defensive medicine to really protect themselves against potential malpractice lawsuits. And small area variations suggest that physicians can vary widely in their medical decision-making and the use of healthcare resources. Scarce medical resources are wasted when they are inappropriately used. So next, I want to discuss the effectiveness of the Certificate of Need, or CON, regulation in controlling healthcare expenditures. So the next slide we're going to jump to is slide 37. So the main objective of CON regulation was to put limits on the expansion of facilities through a state approval process that would allow expansion only if a need was demonstrated for additional services in a community. However, the main effect of CON was the stifling of competition. It virtually had no effect on per patient day expenditures in hospitals and nursing homes. So the reason why CON failed to achieve lower facility operating costs was that the legislation did not address methods of reimbursement and provided no incentives to change patient or physician behavior in the utilization of healthcare services. So in the case of nursing homes, however, CON regulations have been used as financial mechanisms to curb Medicaid costs. Despite a demand for nursing home beds, the CON regulations have constrained the bed supply to curtail utilization. Let me jump to the next slide here. So to be successful, regulatory cost control initiatives must influence the cost of production as well as the quantity of services utilized. The experience in the U.S. has shown that price controls alone are insufficient for controlling total healthcare expenditures, mainly because there's no restraint on quantity. Now, physicians can induce demand and thus increase the quantity of services provided, even though prices may be controlled. So now that we kind of touched on price controls, I did want to briefly go over the role of quality improvement organizations in cost containment. So I'm going to be jumping to slide 42, and here we are. Now, peer review organizations emphasize control of utilization. These organizations are charged with the responsibility to really determine whether care delivered is reasonable, necessary, and provided in the most appropriate setting. So, quality improvement organizations have the authority to deny payment if care is not medically necessary or not delivered in the most appropriate setting. Now, regarding the 4 competition-based cost containment strategies, I wanted to briefly go over these 4 strategies, and they start on slide 44. So we have demand side incentives. So that's cost sharing that provides incentives to the consumer to be more cost efficient in the selection of a plan and in the utilization of services. The second one is supply side regulation. Antitrust laws prohibit business practices that stifle competition among providers. Third one is payer-driven price competition. So this helps overcome some of the inefficiencies of an imperfect healthcare market. It occurs at two different points. First, employers shop for the best value in terms of the cost of premiums and the benefits package. Second, management care organizations shop for the best value from providers of health services. Now, the last one here listed is utilization controls, which is where managed care also helps overcome some of the inefficiencies of an imperfect healthcare market. Managed care is directed toward intervening in the decisions made by care providers to ensure that only appropriate and necessary services are provided and that services are provided efficiently. Now that we went through those 4 competitive strategies, I did want to briefly touch on the Rand Health Insurance Experiment and really just talk about how the findings from this experiment helped reinforce the relationship between growth in third-party reimbursement and increase in healthcare costs. So I'm going to be jumping to slide 46. Here we are. So third-party reimbursement. Before I jump to this relationship between third-party reimbursement and increase in healthcare costs, really quick, the Rand Health Insurance Experiment was just an experimental study of healthcare costs. And it also assessed utilization and outcomes here in the US. So it assigned people randomly to different kinds of plans and kind of followed their behavior from 1974 to 1982. So it was actually a little less than 10 years, but it was a longitudinal study. Now, with the findings, they found that it reinforced this relationship between the growth in third-party reimbursement and the increase in healthcare costs. So third-party reimbursement shifts the burden of healthcare costs from the patient to the insurer by reducing out-of-pocket costs for the patient. There is no incentive for the patient to be cost-conscious when someone else is paying the bill. The theoretical connection between out-of-pocket costs and the utilization of healthcare was empirically demonstrated by the Rand Health Insurance Experiment. So again, this study demonstrated that lower healthcare utilization and expenditures resulted from higher cost sharing. Both utilization and expenditures were the greatest in the free plan that had no cost sharing. So these findings show that a higher proliferation of third-party reimbursement, which results in lower out-of-pocket costs, would result in increased healthcare utilization and increased expenses unless artificial restraints are applied. And I do want you to keep in mind that lower utilization due to cost sharing did not affect most measures of health status. So that's a little bit about the Rand experiment and what was the outcome of the study. And next, I want to address the topic of access. I'm going to jump to slide, first 51. So access is the ability to obtain needed, affordable, convenient, acceptable, and effective personal health services in a timely manner. So when we're talking about access to care, so the key implications of access, there are a number of them that are key implications of access for health and healthcare delivery. So first, access to medical care is one of the key determinants of health status, along with environment, lifestyle, and heredity factors, as we saw with Bloom's model. Access is regarded as a significant benchmark in assessing the effectiveness of the medical care system. So, for example, it can be used to evaluate national trends against specific goals, such as those proposed in the Healthy People initiatives, or to evaluate the performance and accountability of healthcare plans and providers. Measures of access reflect whether or not the delivery of healthcare is equitable. And recently, with the growth of managed care and the integration of healthcare financing and delivery, access is increasingly linked to quality of care and the efficient use of needed services. So next, I really want to touch on the role of enabling and predisposing factors in access to care. So let me jump to the next slide. So here we are. Predisposing and enabling conditions result in some individuals using more medical care services than others. Predisposing conditions include an individual's socio-demographic characteristics such as age, sex, education, marital status, family size, race and ethnicity, and religious preference. These factors indicate the propensity of individuals to use medical care. So, for example, holding everything else constant, elderly people are more likely to use medical care than are young people. Then, when we're talking about enabling conditions, which I think I'm going to jump to the next slide, we're talking about income, socioeconomic status, price of medical services, financing of medical services, and occupation. They focus on the means individuals have at their disposal that enable them to use medical care. So an example would be holding everything else constant. Those with higher incomes are more likely to use medical care than those with lower incomes. Okay, just to kind of give you an idea. Now, there are 5 dimensions of access. So we're going to jump to slide 56 and just briefly go over them. So first, availability. Availability refers to the fit between service capacity and individuals' requirements. So for example, are primary and preventative services available to patients? Are enabling services such as transportation, language, and social services provided? Are there sufficient specialists in the health plan to take care of patients' needs? These are kind of the questions when we're talking about the fit between service capacity and individuals' requirements. Now, accessibility refers to the fit between location of a provider and the location of patients. So, for example, are services convenient to patients? Can the provider location be reached by public or private transportation? Is the provider site designed so that disabled or elderly patients are not inconvenienced? Does the provider accept patients regardless of payment source, for example, Medicare or Medicaid? Next, affordability refers to individuals' ability to pay. Even individuals with insurance often have to consider deductibles and co-payments prior to utilization. So an example would be, are insurance premiums too high? Are deductibles and co-payments reasonable for the services covered under the plan? Accommodation refers to the fit between the manner in which resources are organized to provider services and individuals' ability to take advantage of the arrangement. So, for example, we're talking about are there opportunities for the patient to schedule an appointment? Are scheduled office hours compatible with the work and way of life of most patients? Can most urgent cases be seen within an hour, say? Can most patients with acute but not urgent problems be seen within a day? So these are kind of the the questions regarding accommodation. And last, accessibility, which is based on the attitudes of both patients and providers and refers to the compatibility between patients' attitudes about the personal and practice characteristics of the providers and providers' attitudes about the personal characteristics of the clients. So for example, what is the waiting time for scheduled appointments? Are patients encouraged to ask questions and review their records? Now, we've reviewed the dimensions of access, the 5 dimensions, and next I briefly wanted to go over the 4 main types of access described by Anderson. So I'm going to jump to slide 59 and really quick go over these 4 main types of access. So we have potential access, which refers to healthcare system characteristics such as its capacity, organization, and financing, as well as enabling characteristics, which include personal income, insurance status, and accessibility factors such as transportation. Realized access refers to the type, site, and purpose of health services. So the type of utilization refers to the category of services rendered. So physician, dentist, or other practitioners, hospital or long-term admissions, prescriptions, medical equipment, etc. The site of utilization refers to the place where services were received. So was it an inpatient setting, such as a short-term stay hospital, mental institution, nursing home? So those are kind of a couple of possible places of service. Now, the purpose of utilization refers to the reason medical care was sought out, whether it be primary prevention, diagnosis and treatment, or rehabilitation due to some type of illness. Next, equitable access refers to the distribution of healthcare services according to the patient's self-perceived need or evaluated need as determined by a health professional. Inequitable access refers to services distributed according to enabling characteristics, such as income or insurance status. And last, effective and efficient care links realized access to health outcomes. So for example, does adequate prenatal care lead to successful birth outcomes as measured by birth weight? Is immunization related to reduction of the incidence of vaccine preventable childhood diseases, including like diphtheria, measles, mumps, polio? Are preventative services related to the early detection and diagnosis of treatable diseases? And the concepts of effectiveness and efficiency, do they link access to quality of care? Now, next, I just briefly wanted to talk about the measurement of access to care. So I'm going to jump to slide 61, which is the next slide. And here we're covering the measurement of access at 3 different levels. So access indicators at the individual level. It measures, the measures of medical service utilization is relative to enabling and predisposing factors while controlling for need for care. The patient's assessment of the interaction with the provider. So examples of this include the differences in physician visits by race or ethnicity, gender, age, income, or insurance. And then the patient's perceived level of access is closely related to the patient's satisfaction with care and is part of that access framework. Now, when we're talking about health plan or at the health plan level, indicators include aspects of plan characteristics that affect access, such as price of premium, deductibles, co-payments, coverage for preventative care. or out of plan use. And then you have indicators of access at the level of healthcare delivery system, compromise ecological measures that affect populations rather than individuals. So at this level, system indicators help study access in an environmental context. So how context affects the access of persons and groups. And this is kind of when we're touching on these social determinants of health and looking at these environmental influences. So examples of system access indicators. We have health policies or programs related to access, physician population ratio, hospital beds per 1,000 population, percent of population with insurance coverage, percentage of population without access to primary care physicians. So these just kind of give you an idea of how access is measured and indicators that are used at each one of these levels. Next, I wanted to jump to the topic of quality. And what are some of the implications of the definition of quality proposed by the Institute of Medicine? So I'm going to jump to the next slide, slide 62. Now, the Institute of Medicine defined quality as the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. The definition has several implications, right? So we have quality performance, which occurs on a continuum. So theoretically ranging from unacceptable to excellent. This definition implies that quality can be defined and measured. We have focus. So the focus is on services provided by healthcare delivery system as opposed to individual behaviors. Quality may also be evaluated from the perspective of individuals and populations or communities. So another implication is the emphasis on desired health outcomes. So research evidence must be used to identify the services that improve health outcomes. Now, in the absence of scientific evidence regarding appropriateness of care, professional consensus can be used to develop criteria for defining and measuring quality. So the definition proposed by IOM leaves out the role of cost in the evaluation of quality. Higher costs do not necessarily produce better health. Therefore, quality must be evaluated in relation to cost. The second missing element is the relationship between access and quality. So it is highly unlikely that population-based measures of health would improve in the U.S. without a system that extends basic healthcare to all Americans. So those are some of the implications regarding this definition of quality by IOM, or the Institute of Health. And then at the end, I touched on some of the missing elements regarding this definition. So next, I wanted to discuss the dimensions of quality from the micro and macro perspectives. So I'm going to jump to slide 64. Here we are. So the micro level is associated with the performance of individual caregivers and healthcare organizations. The macro level looks at quality from the standpoint of populations. It reflects the performance of the entire healthcare delivery systems. The entire healthcare delivery system. So the micro dimension of healthcare quality encompasses the clinical aspects of care delivery, the interpersonal aspects of care delivery, as well as the quality of life. Now, the clinical aspects of care deal with technical quality, which evaluates appropriateness of care according to several different criteria. The facilities where care is delivered, the qualifications and skills of caregivers, the processes and interventions used, the cost efficiency of care, and the end results or effects on patients' health are some of the key criteria evaluated to determine clinical appropriateness of care. Now, interpersonal quality focuses on the delivery of care from the patient's perspective. So this includes practitioners' interests, concerns, and demeanor during the clinical encounters. It is important because expressions of love, hope, and compassion can enhance the healing effects of medical treatments. Interpersonal aspects of quality are also important from the standpoint of organizational management because consumers gain lasting impressions of organizational quality from the way they are treated by the employees of an organization. Quality of life evaluates a person's own perception of health, ability to function, role limitations stemming from physical or emotional problems, as well as personal happiness during or after the disease experience. Now, when we're looking at the macro perspective, quality encompasses system-wide efficiencies and outcomes, which includes cost, access, and population health. Life expectancy, mortality rates, cause-specific mortality, low birth weight deliveries, and incidence and prevalence rates for specific diseases are some of the indicators of quality at the macro level. Access to healthcare has considerable influence on population health. Now, there are two types of health-related quality of care. So I know I jumped through the macro view. We went through the micro view and macro view. And now I wanted to jump to the health-related quality of life. So I'm actually going to jump to slide 68. I know I went through a couple of slides without switching my slides. But remember, along with this video lecture, you have a detailed chapter PowerPoint presentation to work with as well as your chapter. And I hope you find all these resources helpful in learning the content. Now, regarding the two types of health-related quality of care. So disease-specific quality of care is associated with the potential quality of life impacts of a specific disorder and its treatment. Disease-specific health-related quality of care quality of life focuses entirely on impairments that are due to a specific disorder and the effects and side effects of treatments for that disorder. So an example would be arthritis quality of life is concerned with joint pain and morbidity and side effects of the anti-inflammatory agents. Depression quality of life deals with the symptoms of depression. Now, institution-related quality of life refers to a patient's feeling of well-being while confined in an institution as an inpatient. So it includes comfort factors related to physical aspects of institutional living, cleanliness, safety, noise levels, odors, air circulation, environmental temperature, and furnishings, and factors that influence the emotional well-being of institutionalized patients. Now that we've went through the disease-specific HRQL as well as institutional-related quality of life, I wanted to briefly go over the basic principles of total quality management, and this is found on slide 74. So let's jump to slide 74 and really just quickly look at the total quality management, the elements that are total quality management encompasses. So we have quality, which is an integrative concept. It must permeate everything that a healthcare delivery organization does. In other words, it is not simply confined to the delivery of health services to patients. TQM, or total quality management, also has the support and commitment of the top levels of management as well as managers at all levels of the organization. There's also a commitment toward ongoing improvement. So this means that standards against which quality is assessed do not remain static. So as soon as the current performance goals are achieved, higher standards are set. So the ultimate goal is to achieve a 0 error rate, right? Or 100% success rate. Even though such a state of perfection may never be attained, goals must nevertheless be set towards its achievement. And everyone working in the organization plays a part in the production of quality of goods and services. Now, total quality management also emphasizes the value of striving to exceed prevailing standards. So this suggests an imperative to study the process throughout the organization by which healthcare is produced and provided. Total quality management needs to be customer driven. The efforts of TQM are directed toward customer satisfaction. So they're both internal and external customers. Internal customers are users of the products or services that ultimately influence the quality of care for patients. So an example, our nursing units are customers of the pharmacy, which must furnish the right medications ordered by the physicians. The pharmacy is the customer of the physicians, who must prescribe legibly and correctly. Patients and communities are the external customers who ultimately benefit from the results of total quality management. Now, before I end this video lecture, because I really don't want it to get too long, I wanted to briefly go over the Donabidian model of quality, and it's found on slide 77. So the Donabidian model consists of 3 domains in which healthcare quality should be examined: structure, process, and outcomes. So they're all equally important in measuring the quality of care. All 3 domains are also complementary and should be used collectively to monitor quality of care. Structure, process, and outcomes are closely linked and are also hierarchical. Structure is the foundation of the quality of healthcare. Good processes require a good structure. So in other words, deficiencies in structure generally have a negative effect on the processes of healthcare delivery. Structure and processes together influence quality outcomes. Structure primarily influences process and has only a sedentary direct influence on outcomes. So it should be noted that the model views quality strictly from the delivery system's perspective. So it doesn't account for the individual lifestyles and behaviors that also have a significant influence on health status. Structure essentially refers to resource inputs used in the delivery of healthcare. So examples: facilities, equipment, staffing levels, staff qualifications, staff training programs, and administrative organizations. Now, from a statewide macro perspective, structural elements include the number of physicians and hospital beds available, the geographic distribution of physicians, hospitals, and nursing home beds, and the mix between primary care and specialist physicians. So structural measures indicate the extent to which healthcare organizations have the capability to provide adequate levels of care. So in other words, structure provides this indirect measure of quality. Now next, we're going to jump to process. So process refers to the actual delivery of healthcare, which includes both technical and interpersonal aspects of delivery. Examples include correct diagnostics tests, correct prescription, accurate drug administration, pharmaceutical care, waiting time for seeing a physician, and interpersonal aspects of healthcare delivery. Now next I'm going to briefly cover outcomes, which are on slide 81. And outcomes refer to the effects or final results obtained from utilizing the structure and processes of healthcare delivery. So positive outcomes suggest recovery from disease and improvement in health. They also suggest an overall improvement in health status through health promotion and disease prevention efforts and adequate access to healthcare services. Outcomes are often gauged through a comparative assessment. So this comparative assessment is really between two time intervals of the measures of morbidity, mortality, and health status. Now, other outcome measures include post-operative infection rates, rates of rehospitalization, and there's another indicator of positive outcome is patient satisfaction. Now, when we're looking at patient satisfaction, it's assessed through questionnaires that are completed by the patients or surrogates, and ratings by consumers provide the most appropriate method for evaluating interpersonal quality. Now, that pretty much covers it from what I'm covering in this video lecture on cost, access, and quality. And I hope you find this video lecture helpful. If you have any questions, don't hesitate to let me know. But remember to go through this PowerPoint presentation in its entirety because I included a lot of detail in order to help you be able to use it kind of as a study tool along with the assigned reading. Best of luck, everyone, and take care.